Alright, very good day to everyone. So far we have focused in the last lecture. We focused mainly on the pediatric condition and gait problem, where the movement issues are closely linked to the growth and also the development of the children. Now we will move on to the adult neurological condition, which present a different set of challenge in orthotic practice. So in adults, neurological condition are usually acquired, meaning that they develop after a period of normal movement. Okay, so this condition may result from events such as the some of the problem that we will discover today, which is stroke, spinal cord injury, traumatic brain injury, or progressive neurological disease. So unlike pediatrics cases where orthoses are used to guide the development, the adult orthotic intervention often aim to restore the function, compensate for the lost control, and also, of course, improve the safety of the user. And adult with neurological condition, they may present with muscle weakness, spasticity, of course, loss of coordination, sensory deficit, or joint instability, and these impairments can significantly affect their gait, balance, and independence in daily activities. So, orthotic management in adult neurological condition mainly focus on functional mobility, such as improving their walking efficiency, preventing falls, enabling participation in work, and also, of course, daily life. And as prosthetics and orthotics mainly, it is important to recognize that the adult orthotic design must consider factors such as fatigue, ease of use, durability, long-term compliance, since adults are expected to use their orthoses independently and also consistently. So in the next few slides, we will explore the common adult neurological condition and how they influence gait patterns and orthotic design decisions. So, one of the most common adult neurological condition you will encounter in orthotic practice is stroke, also known as cerebrovascular accident or CVA, and a stroke occur when there is an interruption of the blood supply to the brain, either due to a blockage or we call it ischemic stroke or bleeding or hemorrhage stroke. So this interruption leads to damage in specific area of the brain, resulting in the loss of motor control and sensation and also coordination. So from a movement perspective, stroke often causes hemiplegia or hemiparesis, where one side of the body is more affected than the other. So this asymmetry has a significant impact on gait, balance, and also functional mobility. So common gait problem following stroke include foot drop, reduced knee control, spasticity, poor balance, and decreased coordination. And many individuals demonstrate compensatory strategies such as all of this we will learn later in this lecture, such as hip hiking, circumduction to clear the foot during swing. And muscle tone after stroke can vary across patient. Some patient develop spasticity, leading to stiff and restricted movement, while other may experience muscle weaknesses and poor motor control. So sensory deficit are also common, further affecting balance and safety during walking. So orthotic intervention following stroke aims to improve walking safety, restore the functional alignment, and also reduce the risk of falls. And AFOs are commonly prescribed to manage foot drop, improve ankle stability, and also enhance the gait symmetry. And in most severe cases where the knee control is also compromised, a KAFO, knee ankle foot orthosis, may be required to provide additional stability during stunts. So the choice of orthosis will depend on the patient's strength, endurance, and also their functional goal. And the design consideration in post-stroke orthotics will include ease of donning and doffing, weight of the device, comfort, and also adaptability in changes in muscle tone and recovery over time. Next, we will discuss spinal cord injury, commonly referred to as SCI, which is another important adult neurological condition in orthotic practice. So, spinal cord injury occur when the spinal cord is damaged due to trauma, such as a road traffic accident, falls, or maybe sport injuries or violence. And this injury disrupts the transmission of the signal between the brain and the body, resulting in loss of motor and sensory function below the level of injury. So, unlike stroke, where impairment usually affect one side of the body, SCI often leads to bilateral involvement, meaning that both sides of the body are affected. So, the severity and the pattern of impairment depend on the level and completeness of the injury. So, injuries at the higher spinal level, as you can see from the slide, generally result in greater functional limitation. For example, injuries in the thoracic or lumbar region may cause paraplegia, affecting the lower limb, while cervical injuries can result in quadriplegia, affecting both upper and lower limbs. And from a gait perspective, individual with incomplete spinal cord injury may retain some voluntary movement but often present with muscle weakness, poor trunk control, knee instability, and reduced balance. So complete injuries may result in an inability to walk independently. Okay, so orthotic management for spinal cord injury focuses on providing stability, enabling standing or walking, and preventing secondary complications such as joint contractures, and maybe pressure sores. So common orthoses include AFO, KAFO, and some cases HKAFO for standing or limited ambulation. Okay, the design consideration for SCI patient include maximum stability, durability, ease of use, and protection of the insensate skin, because sensation may reduce or absent for this type of patient, and careful attention must be paid to pressure distribution and padding to avoid skin breakdown. Okay, next we have traumatic brain injury, commonly known as TBI. Okay, which is another significant adult neurological condition encountered in orthotic practice. So traumatic brain injury occurs when an external force causes damage to the brain, and most commonly due to the road traffic accident, fall, sport injury, or assaults. Unlike stroke, which result from vascular causes, TBI is caused by mechanical trauma to the brain. The clinical presentation of TBI can vary widely depending on the severity and also the location of the injury itself. Some individuals, they may experience mild impairment, while the other may have significant and long-term functional limitation. So from a movement and gait perspective, individual with TBI may present with poor balance, reduced coordination, muscle weakness, spasticity, abnormal muscle tone, or involuntary movement. And gait pattern can be inconsistent and unpredictable, often changing with fatigue or environmental demands. So, orthotic intervention in TBI focus on improving stability, the same supporting safe ambulation, reduce the risk of fall, and AFOs are frequently used to manage ankle instability or foot drop, while more complex orthoses may be required if the knee or trunk control is compromised. And the design for TBI orthoses includes simplicity, ease of donning and doffing, durability and comfort, because motor control and cognitive function may fluctuate. Okay, so orthoses should be intuitive to use and forgiving of minor error in application. And as engineer, we need to understand that TBI highlights the importance of designing orthotic device that addressing not only biomechanical deficit but also cognitive and behavioral factors that influence the real world use. Okay, and then we have multiple sclerosis, we call it as MS. Okay, this type of problem, commonly known as MS, is a chronic neurological condition frequently encountered in adult orthotic practice. Or multiple sclerosis is an autoimmune disease that affects the CNS, the central nervous system, specifically the brain and also the spinal cord. In MS, the immune system attack the protective covering of the nerve fiber known as myelin, disrupting the transmission of the nerve signal. And one of the key features of MS is that its symptom can be variable and also unpredictable. Individual may experience periods of symptom worsening known as relapse, followed by periods of partial or full recovery known as remission. And from movement and gait perspective, people with MS commonly present with muscle weakness, fatigue, and then poor balance, spasticity, reduced coordination, and also sensory disturbances. And this impairment can fluctuate throughout the day and may be worsened with heat and also physical exertion. So gait abnormalities in MS often include foot drop, reduced walking speed, shortened stride length, and increased instability during stance. So fatigue plays a significant role, making walking increasingly difficult over time. Orthotic intervention in MS focuses on energy conservation, stability, and also safety. AFOs are commonly prescribed to assist with dorsiflexion, improve the foot clearance during swing, and also reduce the effort required for walking. So design consideration for orthoses in MS include lightweight material, ease of use, comfort, and also adaptability, because symptom may change over time, and orthoses must be adjustable for easily modified to accommodate progression or fluctuation of the condition. So it is also important to consider that the individual with MS, they may have reduced sensation. Making careful attention to pressure distribution and also padding are very essential. Okay, so MS highlight the need for orthotic design. They are flexible, efficient, and user-centered, allowing individuals to maintain independence despite a fluctuating condition. And we have Parkinson disease. Parkinson is also progressive neurological condition disorder that primarily affects the movement control. Okay, so Parkinson disease results from the gradual loss of dopamine producing neurons in the brain, particularly in the areas responsible for regulating the movement. Okay, so this leads to characteristic motor symptoms that worsen over time, and the most common movement features of Parkinson disease include bradykinesia, which is slowness of movement, and then they have muscle rigidity, tremor at rest, and also postural instability. These impairments significantly affect the gait and also the balance of the patient. And from the gait perspective, individual with this disease, this Parkinson disease, they often present with a shuffling gait, reduced step length, and diminished arm swing, and difficulty initiating movement. And some patients experience freezing of gait when they are temporarily feel unable to move their feet forward. And as the disease progresses, we can see that balance become increasingly compromised, increasing the risk of fall. Turning, stopping, and navigating narrow spaces can be particularly challenging for this type of disease, this type of patient. So orthotic intervention in Parkinson disease is generally aimed at improving the stability, posture, and also safety, rather than correcting any specific joint deformity. And foot orthosis or AFO may be used to enhance the stability and provide proprioceptive feedback. And the design consideration include ensuring that the orthosis is lightweight and easy to use, as an excessive rigidity may worsen gait initiation and initiation difficulties. Okay, comfort and user acceptance are especially very important given the long-term nature of the condition, and then the orthoses are often used in combination with other strategies such as physiotherapy and also assistive devices to maximize the functional mobility of the Parkinson disease. Parkinson people with Parkinson disease. Okay, so Parkinson disease, they highlight the importance of designing orthoses that support mobility without interfering with natural movement pattern or increasing cognitive load. And then the last one we will discuss on the peripheral nerve injuries, which are a common cause of focal weakness and functional limitation encountered in orthotic practice. Peripheral nerve injuries occur when nerve outside of the brain, and you know where is the position of the peripheral nerve, and they are damaged due to trauma, and maybe compression, prolonged pressure, or maybe surgery, or systemic conditions such as diabetes. So unlike central neurological condition, peripheral nerve injury affects specific muscle or muscle group depending on which nerve is involved. Okay, so common example include peroneal nerve injury, femoral nerve injury, radial nerve palsy, and ulnar nerve injury, and each of these result in characteristic pattern of muscle weakness and functional impairment. So from a gait perspective, one of the most frequently encountered peripheral nerve injury is peroneal nerve palsy, which leads to foot drop, and then the weakness of the dorsiflexor muscle causes difficulty clearing the foot during swing, increasing the risk of tripping and also falls. Okay, so femoral nerve injury, on the other hand, can result in quadricep weakness, leading to knee instability or knee buckling during stance, and this significantly affect walking safety and may require higher level orthotic support. Unlike progressive neurological disease, peripheral nerve injury, they may be temporary or permanent depending on the severity and the cause of injury. Some patients may recover function over time, while the other may require long-term orthotic support. Okay, so orthotic intervention for this type of patient for peripheral nerve injury focuses on substituting for lost muscle function, stabilizing the affected joint, and also restoring functional movement pattern. And commonly AFOs are used for foot drop, while KAFO may be required when knee control is compromised. So design consideration may include selecting the appropriate level of support, ensuring an orthotic is lightweight and comfortable for the patient, and also allowing for potential recovery of nerve function. Okay, so peripheral nerve injury highlights how orthotic design often involves functional substitution, where the device is temporarily or permanently replaces the action of weakened muscle to enable safe and effective movement. Alright, so far we have discussed various neurological conditions in both children and also adults, such as cerebral palsy, stroke, spinal cord injury, and also peripheral nerve injuries. However, in orthotic practice, we do not design orthoses based on the medical diagnosis alone. Instead, we focus on how this neurological condition affect movement, particularly the gait. Okay. So neurological gait deviation describe the abnormal walking pattern that result from impaired muscle control, abnormal muscle tone, weakened sensory loss, or poor coordination, which caused by the neurological injury or disease. So different neurological condition may produce similar gait deviation. Same with the pediatrics, I explained in the last lecture. While the same condition may present differently in different individuals. This is why understanding the gait deviation is essential for effective orthotic design. So as an orthotist, you should train yourself to observe when the patient is walking. You need to see which joint are affected, okay, during which phase of the gait the problem occur, and how the body compensates to maintain balance and forward progression. And neurological gait deviation provide valuable information, which is about which muscle are weak, which joint has lack of control and where orthotic support is needed. And in the few next slide, we will focus on common neurological gait deviation that you must be able to recognize and understand. And these include deviations such as foot drop, circumduction gait, vaulting, hip hiking, and other compensatory movement pattern. And by learning this gait deviation, you will be able to link the clinical observation to orthotic design decision, which is a key skill in industrial orthotic practice. One of the most common neurological gait deviation that you will encounter in orthotic practice is foot drop. Foot drop refers to the inability to actively lift the foot upward, particularly during the swing phase of the gait. If you like try to see, if you're walking, you see that your foot will go up while will do dorsiflexion while they are trying to clear the grounds. But foot drop, they are not able to actively lift the foot upward, and um, as a result, the toes may drag along the ground, increasing the risk of tripping and also falling. From neurological perspective, foot drop is usually caused by the weakness or the paralysis of the ankle dorsiflexor muscle, and this weakness may result from conditions such as stroke, peroneal nerve injury, spinal cord injury, TBI, traumatic brain injury, and also MS, multiple sclerosis. So when dorsiflexion is insufficient during swing, the body often compensates using alternative movement strategies, and common compensation includes hip hiking, circumduction, or excessive knee flexion, which increase the energy expenditure and reduce gait efficiency. And foot drop is primarily a problem during the swing phase, but it can also affect initial contact instead of controlled heel strike. The foot may land flat on the or slap onto the ground, reducing the stability and shock absorption. So in orthotic practice, foot drop is commonly managed using ankle foot orthosis (AFO). The main goal of the orthosis is to assist or substitute dorsiflexion, ensuring they have adequate foot clearance during swing phase and safer for the foot placement during stance. And design consideration includes the amount of dorsiflexion assistance provided, the stiffness of the orthosis, and also the balance between supporting swing phase while allowing sufficient plantar flexion for push off. So as an orthotis, it is important for us to recognize the foot drop as a functional gait deviation, not just a muscle weakness. So your orthotic design should directly address the movement problem observed while minimizing compensatory strategies and improving overall walking safety. So understanding foot drop will help you to link neurological impact to visible gait deviation and translate the understanding into effective orthotic solution. We now have we will discuss now on the circumduction gait, which is a common compensatory gait deviation seen in individual with neurological impairment. And circumduction, if you see from the slide, it occurs when the leg they swing outward in semicircular arc during the swing phase rather than moving straight forward. So this movement is used to help the foot clear the ground when normal swing phase mechanics are impaired. And from a neurological and biomechanical perspective, circumduction gait is often associated with foot drop, reduced knee flexion, or joint stiffness because the individual cannot adequately lift or bend the leg. So they compensate by moving the leg laterally, and circumduction is frequently observed in conditions such as stroke, peroneal nerve injury, spinal cord injury, TBI, and it's especially common in individuals with unilateral weakness where one of the leg is more affected than the other. Okay, so while circumduction may help to prevent the toe drag, it come at a cost. The gait pattern increases energy expenditure. It will disrupt the balance and place additional stress on the hip and lower back. So in orthotic practice, circumduction gait is an important observation because it often indicates insufficient ankle dorsiflexion assistant or knee flexion during swing. So addressing the underlying cause can reduce the need for this compensatory movement. Then we have the hip hiking. Sorry, 1 minute. So hip hiking is also another common compensatory gait deviation seen in individuals with neurological musculoskeletal impairment. So hip hiking occurs when the person they elevate one side of the pelvis during the swing phase of gait in order to clear the foot, also to clear the foot from the ground. So this movement is typically used when normal leg swing is compromised, and from a biomechanical perspective, hip hiking is often a response to a foot drop, reduce knee flexion or stiffness at the ankle or knee. So when foot cannot be lifted adequately during swing, raising the pelvis become a strategy to avoid toe drag. Okay, so hip hiking is a frequent observed in conditions such as also the same stroke, spinal cord injury, traumatic brain injury, and peripheral nerve injury, and it's especially common in individuals with unilateral weaknesses, where one side of the body is more affected. And although hip hiking may allow the foot clearance, the same with circumduction, it will describe the normal smooth motion of the gait and increase the energy expenditure, and over time this can lead to fatigue and strain on the lower back or hip muscle. So this is among one of the important observation that you need to know, because it's often indicate insufficient support at the ankle or knee, particularly during the swing phase, and addressing this underlying cause can reduce the need for compensatory movement. And orthotic intervention may involve the use of ankle foot orthosis to assist in dorsiflexion, so they don't need to do hip hiking anymore. Can improve foot clearance and stabilize the ankle, and in some cases additional knee support may be required if the knee control is also compromised. And the design consideration for the orthosis include ensuring adequate dorsiflexion resistance, proper alignment, and also sufficient clearance during swing while maintaining comfort and functional movement. We have vaulting. Is also another compensatory gait deviation commonly seen in individual with neurological impairment. Vaulting gait occur when the person rises up onto the toes of the stance leg in order to create extra clearance for the opposite swinging leg. So in simple term, the person pushes up on the supporting leg to help the other leg move forward without dragging. Okay, so from biomechanical perspective, vaulting is usually a compensation for the inadequate foot clearance during swing, and this may be caused by the same foot drop, reduced knee flexion, and maybe they have limb length discrepancy. This usually happen in limb length discrepancy, where one of the leg is shorter than the other, and or stiffness in the swinging leg. Okay, vaulting gait is often observed in conditions such as stroke, spinal cord injury, traumatic brain injury, or peripheral nerve injury, and it's especially common when orthotic support on the affected side is insufficient or when the limb clearance is restricted. Okay, although vaulting can help to prevent the tripping, but the same energy expenditure will take place, and then it will give like more stress, additional stress on the calf muscle or ankle of the stance limb. Okay, and over the time this may lead to fatigue, calf pain, or secondary musculoskeletal problem. For orthotic practice, vaulting gait is also one of the important signs that you must see, and then you must know that this is the indication of inadequate dorsiflexion assistance, and the orthotic that you can prescribe must aim to improve the swing phase clearance, by providing an AFO to assist dorsiflexion, or by adjusting orthotic alignment to allow smoother limb advancement. And then we have the ataxia gait, which is also neurological gait deviation caused primarily by the poor coordination rather than muscle weakness or abnormal muscle tone. And ataxic gait is characterized by the unsteady, irregular, and poorly coordinated walking. Individuals often appear unstable with inconsistent step length and timing, and they have difficulty in maintaining balance during walking. Okay, this gait pattern is most commonly associated with a cerebellar involvement, as the cerebellum plays a key role in coordination. So when they have problem with that, so coordination become a problem, then they will have balance, and they will have problem with balance and also movement timing. So ataxic gait may be seen in conditions such as cerebral palsy, traumatic brain injury, stroke that involve the cerebellum, and multiple sclerosis. And from the observational perspective, individual with this type of gait, they often walk with a wide base support, excessive trunk sway, and variable foot placement. Okay, these are the compensatory strategies used to increase the stability when coordination is impaired. So this ataxia gait, unlike the spastic or flaccid gait pattern, this type of gait is not caused by tightness or paralysis. Instead, the problem lies in the or muscle activation, making the movement unpredictable and inefficient. So common orthotic approach include AFOs or stable footwear in order to create more secure base of support. However, over restricting movement should be avoided, as it may further interfere with the coordination of the user. Okay, so ataxic gait, if you can see, is highlight the importance of the tailoring orthotic intervention to the underlying neurological condition problem rather than applying the same design strategy to all gait deviation. Okay, we will discuss now on the reduced dorsiflexion, which is very common also, impairment underlying many neurological gait deviation. So dorsiflexion, dorsiflexion and plantar flexion. Dorsiflexion refers to the ability to lift the foot upward and the ankle, bringing the toes down toward the shin. And reduced dorsiflexion means that the movement is limited, weak, or poorly controlled. And reduced dorsiflexion can occur for several reasons, including muscle weakness, spasticity of the plantar flexors, muscle tightness, contracture, or impaired motor control due to neurological condition. So reduced dorsiflexion is commonly seen in conditions such as stroke, CP, peroneal nerve injury, SCI, MS, and also TBI. So from a gait perspective, reduced dorsiflexion, it will affect both swing and stance phase, and during swing phase, inadequate dorsiflexion can lead to toe drag, increasing the risk of tripping. And then during stance phase, limited dorsiflexion can interfere with the smooth forward progression of the body, and because of this limitation, individuals often they adopt the compensatory strategies such as hip hiking, circumduction, and also vaulting that we have discussed just now. And in orthotic practice, the reduced dorsiflexion is a key indication for prescribing an AFO, and the goal for this AFO is to assist or control ankle motion, improve the foot clearance during swing, and also promote a more stable and efficient gait pattern. Okay. Next, we will discuss on the knee buckling, which is commonly occur due to the weakness of the quadricep muscle. And the quadricep muscle, they play a critical role in controlling the knee extension during stance. When these muscles are weak or unable to activate effectively, then the knee may collapse or give way under body weight. And a phenomenon known as knee buckling is most evident during the stance phase of the gait, when the knee is required to support the body and prevent collapse. Okay, individual with knee buckling, they often feel unstable. They may be at high risk of falling, of course, and neurologically, they have weak quadricep, and knee buckling are commonly seen in conditions such as stroke, SCI, femoral nerve injury, traumatic brain injury, and multiple sclerosis, and usually to compensate this quadricep weakness in these individual, they may adopt strategies such as locking the knee into hyperextension and leaning the trunk forward or reducing walk speed to increase stability. While these strategies may prevent collapse, they place abnormal stress on the knee joint and surrounding structure. Okay, so design consideration for this type of patient must include controlling the knee motion during stance, and then ensure that adequate stability while allowing functional movement, and selecting appropriate locking or stance control mechanism if required. Okay, so knee buckling, they highlights the importance of designing orthoses that provide reliable stance with stability, particularly for individuals with significant muscle weakness and neurological impairment. And then we have the last one, I think, spasticity related stiffness. For this spasticity related stiffness, I will discuss with you in the next lecture, where we will continue with the uh, orthopedic and traumatic condition, which usually includes fractures, ligament injuries, tendon injuries, post-surgical stabilization, knee osteoarthritis, and also ankle sprain, instability, and some terminology that are related to lower limb orthopedic. Okay, I will provide with you some question related to the pediatric and also neurological problem, and please answer this 20 questions of multi MCQ, and don't worry, this is just to test your understanding about what the common problem in the pediatric and also neurological condition that requires the use of orthotic intervention. Alright, thank you so much for listening to this lecture. We'll continue the next lecture. Maybe I will upload the next lecture video on next week. Alright, thank you.